Okay. Hi, everybody. Well, we have election results, and I'm happy to share. If I can have your attention, if the winners are in the room, please stand up so we can see who you are. For the Afro region, Gloria Ekin. All right. She's not here. Okay, well, Gloria, congratulations. From the Edinburgh region, we have Yasser Dawadian. So I think it's also not. Yeah, okay. From Euro, we have Kagan Kalbusuglu. Not here. Paho, I know Tom Norris is not here, but he's the winner. Congratulations, Tom Norris. From Zero, we have Dr. Aurora. Welcome back. And WPR region, we have, you'll be shocked at this winner, Edmund Lau, who ran unopposed. Thank all of the past members of the council, and thank you for your service and your assistance, and we look forward to working with the new council. So now we're going to have a break. We're going to end our council meeting, and we are going to take a roughly 10-minute break. Great. Hello, everybody, and welcome to the second conference of the World Took a long time to get here, didn't it? Welcome to Africa. People have never been to Africa before. No, I haven't. This is great. What a beautiful place. So, welcome to Cape Town. Welcome to our conference. We have 2 days packed with information, and it's information that you asked for. You all know that we do an annual survey at the beginning of every year, and we take really seriously what all of you say that you need, what your organization needs. And we drive all of our programming for that year and for our conferences based on exactly what you need. So we brought together some of the top speakers in the world on healthcare policy, on access, on all of the things that you've seen in the agenda. And we have a really action-packed 2 days for you. And I'm really excited about this conference because not only will you learn a lot from the speakers in the sessions, but just as valuable is the networking that will happen on breaks, and all of you meet each other. And I'm already hearing about projects that are being developed together, side conversations, including our organization. So it's really exciting to be together instead of on a Zoom platform that we've all become so used to. And it's really great to be here together. So I'm not going to spend an hour introducing the World Patients Alliance. We're going to have a couple of slides.
Yeah, his mic is still off now, but I can unmute him really as long as he comes in.
And to introduce you to the person that put together this conference, that ran the conference, that helped pick our speakers, our conference chair and board member and co-founders of the Ramada. She's going to say a couple of words.
Thank you very much, Andrew. I am very delighted to see everyone here today. It's been long hours of work to put this together, and I want to thank everyone for their contribution. And I know that already this is a success. Thank you all for coming all the way to this meeting. I know it's been a lot of travel and stressing at some point, but I'm glad you're here. I know that you all have very busy schedules, but we really value your taking the time to be with us here today. We do not take that for granted. Thank you for being here as we discuss in this conference the evolving role of the patient in the changing world. I'm sure you're aware that today a lot is happening. There's lots of technological advancements where the patient is supposed to take a more active role to be able to be at the moment and utilize all the opportunities therein. Some of these advancements include telemedicine, devices that you wear. I'm sure I can see that many of you are wearing smart watches, which help give you reminders for your medications and other health tips. Robotics in surgery, genomics and precision medicines, artificial intelligence, genetic testing, blockchain for security of health data, and many others. But these come with lots of opportunities, but with challenges as well, and cause for collective action. And this is the reason why we are here today. With all these key stakeholders, as you can see, to work together, to network. There are so many fragmented efforts around, but when we come together and share what is happening everywhere, we are better able to create solutions and able to support the patients. I'm also happy to note that increasingly, patients are being recognized as critical partners. And they're also evolving, trying to meet up with the new opportunities to be able to actively participate. It's no longer the days where patients were being looked at as passive receivers of care, but with just their body and mind. But now they're also being looked at as key players who can make their contribution. And I just want to commend the organization, the partners that are doing that, including WHO, FDA, EMA, and others. Industry as well. I know Pfizer also has a patient-centric approach. These are all commendable. But I also want to say that, especially in low and middle-income countries, we're still lagging behind. There are still pockets of paternalism where the patients are still looked at as passive receivers of care, and the doctor knows it all. But we know that the word is fortitude, persistence, resilience, not giving up. We will get there. Like working together and making sure that we get the patient-centered healthcare that every patient deserves, everywhere, whatever place they come from. Dear ladies and gentlemen, we value your contributions, and we encourage you in these 2 days to share freely your knowledge, your expertise, so that together we are able to enhance the quality of care for our patients. Thank you very much for participating.
Thank you very much, Regina, for all of your time and your effort and your skills in bringing this conference together and in helping the World Patients Alliance succeed. And I join in thanking our other board members, Penny Cohen, Yolanta, and Carla, and Hussein. We're all volunteers. We don't get paid for being board members of the World Patients Alliance, and it takes a lot of time from our lives. And I really want to thank my fellow board members for all the time that they put into the organization. A special thank you, of course, to all of our sponsors, because it takes a lot of money to put a conference like this together. We were able to support about 70 people who put in for travel grants. We actually had over 500 applications for travel grants. And the only reason that we couldn't get more is financial constraints. But of course, this room only holds 150 people. We didn't expect that we would have more than 500 people that wanted to come to this conference. And we'll definitely keep that in mind in the future. But there's more than 1,000 people that have registered online. So we welcome all of those who are watching online and who couldn't come here to the beautiful place in person. But we're really thrilled that all of you online are participating. The next thing I want to do is introduce perhaps the most important person at the World Patients Alliance. That is our co-founder, our board member, and our now CEO, Hussein Jaffrey. Hussein is running this organization day to day, and he is really solely responsible for everything happening and the success of the organization. So big hand and. Things can take over and tell you a little bit more about the World Patients Alliance.
Thanks, Andy. I'm blushing. Thank you very much for such a warm welcome. Welcome everybody. I'm so happy to see all of you here. I think there's a tremendous progress that we have made since our last conference in Rome. I think we are a totally different organization. I think last time when we met in Rome, I think we were less than half the size of the organization that we are. And in the last 2 years, the sort of progress that we have made, that has only been possible because all of your support. And thank you very much for being here. So I'm not going to take most of your time. I just wanted to give you a very small, an overview of the organization for people who are new. And we are also joined by our partners, international stakeholders. So just a very simple 4 or 5 slides, nothing more than that. So we are by far the largest umbrella patient organization in the world that works across all these areas. We provide that platform to empower patients' voice and for the provision of safe and affordable and quality healthcare all over the world. And we also want to ensure that patients play an active role in all stages of the healthcare, right from the beginning towards the very end. This is our member map. So the green color shows the countries where we have our members. So we are almost everywhere except for a few countries that we are everywhere through our members. So we have 629 member organization in 132 countries. And if you look at our membership in the continents, that's also quite significant. Even if in Africa, you can see, the slide is not right, but it's 196 members only in Africa. And I think this is folders, and these numbers are not correct, but, so we have around 150 plus, members in most of the parts of the world as well. This is our board of directors. So Andrew Spiegel, our board chair, is here. Regina Komoga, our board director, is here. Carla, are you here? Carla, can you stand up so that people can see you? So Carla is here, and she's from Peru, our board of director. Regina, you already met. Penny Coban from the US, and then myself and Yolanta Belinska, our treasurer. If you are in this conference, you can't miss Yolanta, so I don't have to introduce you. If you don't know her, you would know her very well by the end of this conference. So, and then this is our advisory board. So we have, advisory board as well. We have 12 advisory board members. So we have divided the world into 6 world regions. So from each world region, we have 2 advisory board members. So these are the WHO world regions. So, if our advisory board members are here, can you please stand up? Dr. Rhoda is here. Natalia is here. Vidana is here. I think Matia was here as well. So these are our board members. So 6 of them are here, and 6 of them are here. Ingrid was also here somewhere. So most of them are present in the conference. And I would really like to thank our sponsors. Without you, we would not have been able to organize this meeting. Thanks to our board level sponsor, Johnson & Johnson, and also to our silver level sponsor, Pfizer and Sorono, and then our bronze level sponsor, IFPM and Pharma, Estelab, and Executive. Thank you very much for your tremendous support. And we also want to thank our local partners from Africa. They are in South African Depression and Anxiety Group, SADC. And Fatma, thank you very much for your support that you provided. Wow. There are member organizations. Wherever we organize events, our members are basically helping us, and many thanks to SADC for this support. So now it brings us to session number 1 of the day, and it is on access to healthcare. I would like to invite the chair of this session. It is Professor Amish Dhai. She is from the World Medical Association. She is the founder and past director of the Steve Biko Center for Bioethics at the Wits Faculty of Health Sciences and professor of Bioethics and Health Law at the Wits School. She is immediate past chair of the UNESCO International Bioethics Committee. So can I request Professor Dhai?
Good morning, colleagues. Thank you, Chair, for the introduction. It's so wonderful to see the World Patient Alliance growing so rapidly over the last 2 years from strength to strength. And patients, you take ownership of your health and you determine your destiny, especially as critical partners in your relationship with healthcare professionals and with policymakers. And I'm so glad to see this advocacy alliance for patients, something that I didn't even dream of when I qualified as a doctor in 1970. So you know how old I am now. So I'm representing the World Medical Association. So I think I need to give you a bit of a background of the World Medical Association and its interest in patient care and access to health care. So the World Medical Association is an organization which is the Global Federation of National Medical Associations, and it represents 10 million physicians worldwide. It's made up of over 110 National Medical Association members. And in addition to this, it has individual associate members. It was founded in 1947 in Paris. Now, acting on behalf of patients and physicians, the World Medical Association endeavors to achieve the highest possible standards of medical care. And these highest possible standards include access to quality health. I do not believe that we should talk about access to healthcare without qualifying it in terms of quality healthcare. It also endeavors to achieve ethics, education, health, and health-related human rights for all people. So its fields of activities are threefold: ethical guidance, that's policy making at an international level; advocacy and representation; service and outreach. It's got a number of major declarations, which are international policy guidelines. And I'm sure you are familiar with some of these, for example, the Declaration of Geneva, the International Code of Medical Ethics, the Declaration of Helsinki, which actually is for research, but it puts the patient at the center and states categorically that the interests of science and society cannot supersede the interests of patients. And all its declarations actually place the patients at the center of care and stress patient self-determination. And with this as a background on the World Medical Association, it gives me great pleasure to chair the session on access to health care. Now, access to health care is a basic human right. It's enshrined in several international legal instruments. But it Is it a human right that plays out as a human right in the international legal instruments? Or are these international legal instruments playing just lip service to a basic human right? And this is where you, as patients, need to take that fight forward in terms of realizing that right to healthcare is implemented for all globally. Now, the access to healthcare includes freedoms and entitlements. And the freedoms, the right to bodily integrity, so that's where your self-determination comes in. Nothing can be fostered upon you without your interaction and participation in that decision. And entitlements would be the right to access the healthcare without discrimination. And there are core components to this. And these core components come from the World Health Organization, which are availability, accessibility, acceptability, and quality. And sadly, there are impediments to these components and health impediments to these rights, ranging from systems failures to lack of trained healthcare personnel, to geographic impairments. You have the geographic divides, lack of transportation. In other words, social determinants of health that are so important. And we also sadly see civil wars impeding access to healthcare, and also now national wars, for example, Gaza, where we find millions without healthcare access. And we've talked about advancements, technological advancements, but what about the digital divide? So without me actually seeing the thunder of what's going to follow in the session by our speakers, I'll now move on to introducing the moderator for this panel.
Yes.
Our moderator is Candace Henley, who is the Director of Equity and Partnerships, Global Colon Cancer Association. She is also the Chief Surviving Officer of the Blue Hat Foundation and has over 15 years of tireless advocacy for colon cancer prevention and support. And over to you, Candace.
Okay.
Good morning.
Okay, I hear you.
Because, I don't think that dance party. Good morning, and
Okay.
thank you all so much for being here, and it's such an honor to be with you, moderate this panel. I think.
Okay, yeah, I've got it.
Access to healthcare is really important, and it's beyond it being a fundamental right. It is just the fact that, why do we have to say that in the first place? And so I'm so happy that we will be able to introduce her and hear some more from our speakers.
Thing it's one white.
Somebody knows how to dance with me. That's what I'm talking about. So without further ado, I would like to.
Now this one quality is nice. Just take out the cable, the HDMI cable, take it out and put it back in.
Which one? Maybe this one.
No, the one from. Yeah, the one on the front.
We have Mandir Latif. Dr. Is that online? Okay, go ahead. And Dr. Really, Bode, right? Yes, I got it. I got it. I'm sorry. And we have
You
Dr.
want
Andre.
doctor's presentation?
Is
Sorry?
that who's online? He's online?
Yeah.
Okay.
No,
all right.
this one, this person,
Yeah.
that, from their
And,
laptop.
if we can briefly have your introduction, please, and introduce yourself and Don't make sure you survive it. It's like a judge's paper. My name is Tumi Ramasodi. I am a 4 years colon cancer survivor and patient advocate and the regional director for Southern Africa for Global Colon Cancer Association. Good morning, everybody. I'm Dr. Hilencha. Currently holding the office of the Chief Director for Hospitals and Tissue Health Services at the National Department of Health. By qualification, I'm a medical doctor, I'm a public health medicine specialist, and I do have experience in both public and private sector of over 18 years or so. So I'm quite passionate with health systems and strengthening health systems and just ensuring that the platform at which we provide health services actually respond to the needs of our patients that we serve every day. Thank you. Thank you. Thank you.
The live streaming has ended. And then,
Ended.
yeah, and then unexpected error has.
I'm still there. I don't understand why it's ended.
In our ongoing fight for healthcare and justice, let us all remember the words of Nelson Mandela that said health cannot be a question of income, it is a fundamental human right. Patients shouldn't be treated better simply because they can afford to pay. So in 2020, I was living my life, looking forward to my birthday, which was in August. This is July. I'm planning a big celebration for myself, and but I've been having these stomach complications that have been going on for over a year. For as long as I can remember, I was always told that I have stomach ulcers, and then it changed to IBS. And then at some point, it was Crohn's disease. But during that time in 2020, when the country was going through lockdown, I had an emergency visit the ER where I had just non-stop diarrhea, just complications. I came out of the hospital without a proper diagnosis, and I went back to carry on to live my life. And at that point, I had started having stomach cramps that wouldn't go away. Out of my frustration, going back and forth with the doctor, I eventually decided to request for a specialist opinion. I saw the specialist and I told the specialist, I said to my GP, I'm done, can I see a specialist? And luckily he referred me to one. And after I told the specialist my symptoms, the funny one that he really picked up that I didn't consider a symptom because I didn't know what I know now. And I say the story because I remember during lockdown when everybody was locked up in our houses and people were just eating. People were saying, we are gaining weight. But for me, I was excited at the time. I said, oh, but I'm losing weight. Lockdown is treating me well. And I wasn't aware that something big is happening. And so when I visited the specialist and he said, what are your symptoms? I told him what I'm seeing. And I mean, I'm not thinking cancer, and I'm sure at the time he also wasn't thinking that. But when he said to me, are you losing weight? I suddenly realized that actually I'm losing weight. And he said, "Are you doing anything to lose weight?" And I said, "No." But then that's when he realized that something we need to do as school.
Came back and said, "My dear, I have good and bad news." I said, "The good news first." He said, "You came on time." I said, "The bad news." He said, "You actually have colon cancer." At that point, my world turned upside down because cancer? Why me? At that point, you start questioning the world, God, everything. But what did I do wrong? But anyway, before I could process this diagnosis, the surgeon said, "We are operating next week to remove the tumor." We removed the tumor. I woke up and I was told the operation took 11 hours, and I was like, "Yo, this is major." Then I'm starting to get scared because I'm realizing that this diagnosis is bigger than I had anticipated. Okay, and then I was told, "We will do chemo." When I heard the word chemo, I got even more scared because I thought after they cut the tumor, it's done, I'm sorted. But when they mentioned chemo, chemo is a scary word for someone that is not in a medical background or someone that hasn't been exposed to it before. So at that point, I thought, if I'm doing chemo, it really does mean that I'm dying, you know. I waited for medical aid to authorize chemo. After a while, feedback came and I was told when I'll start chemo. But at that time, I'm still very confused and very scared in terms of what is going to happen to me. I eventually had to contact my oncologist and say, "Can I see you?" I went to his office. He said, "We are not due to see you until the 5th of October when you start your chemo." And I was like, "But that is the point. I feel like I need to see you before I start chemo. What is chemo? What is chemo going to do to my body? What am I going to experience? Am I going to survive chemo? Will my body be able to handle chemo?" Somebody needs to speak to me, and nobody's saying anything. And I'm frustrated and I'm scared and I'm worried. At that point, he looked at me and then he said, "Miss Ramasori, okay, this is what's going to happen." Fast forward, I started chemo. I did Folfox. I did 6 months of chemo. I didn't have to do radiation. At this point, I'm still under management of cancer. But then I want us to then speak about, after hearing my story, to then look at the healthcare system and how it is in South Africa. In South Africa, we have a two-tier system. There's the public and the private healthcare. Public healthcare is 84% of the population, and private healthcare is 16%. This is because of who affords. Income still plays a major role in terms of who gets access to private and public healthcare. And the thing is, of course, private healthcare will be better because people can pay. So if you can afford, you can afford but better medical care. I learned as I worked with patients in public hospitals after I started taking on this journey and deciding that because I have been saved, I said to God, if you save my life, I'm going to work with colon cancer patients, and I'm going to make sure that nobody goes through a cancer diagnosis as confused and as anxious as I was during my time. And this is why I'm doing the work that I do and being a patient advocate. And as I work with patients now, I learn a lot of things in the medical space, and I realize that there is so much little budget for cancer and other NCDs. And this is because HIV takes the chunk of the money that the national department allocates. And maybe it is because there isn't enough coming out of the cancer space. And I will speak for cancer because that's the space that I'm very familiar with. There isn't a lot of data coming out of the cancer space to enable reporting, proper reporting to national, so that proper funds can be allocated for cancer patients. Disparities still play a major role in access to healthcare in our country. As I spoke about affordability and the ability to pay, there is the referral system that is in place in our public hospitals, which is a time factor, which is a delay in diagnosing the patients and creates complications at the end of the day. The cost of medication and diagnostic tests and specialist care is also an issue, and who accesses that? Those that can pay. Urban and rural imbalances also play a major role because there's an issue of transportation. People in the rural areas do not even have proper facilities. When you are in an urban area and you have relatives in the rurals, you'll find that when people start falling sick, they come and stay with you for a while because they need to access healthcare, and they can only access it in the urban areas. So in our townships, in the urban spaces, you find a lot of rural people that are being hosted just so that they can access healthcare. Another thing is, if they don't have that opportunity, then they need to travel. Do they have money to travel? Do they have time to move from one province to another so that they can just access specialized care? It's a problem. There are excessive waiting periods in our system. There's lack of staff training and qualified staff within the public healthcare system. And this is also a time delay factor, which also affects the referral system, because at the primary healthcare space, most of the healthcare professionals in that space are not skilled enough to diagnose some of the illnesses, and that also causes a delay in that sense. There's lack of staff in major hospitals. Patients come in very early in the morning to wait for medical attention. And I mean, people come in as early as 4 a.m. just so that they can be seen in that day. And unfortunately, some people come in, the queues are so long that eventually the queues will be cut. You were there from 6, but ultimately we cannot see you today because there's so many of you and we can only handle so many people. It's just, a lot needs to be done. A lot needs to be done. If we say, if access to healthcare is considered a human right, who is considered human enough to have that right? It's a question that I want all of us in this room to ask ourselves as we move throughout this conference. NHI, is NHI the solution for South Africa? It is a proposed insurance for South Africa, and apparently it will address disparities by creating a single unified healthcare system for all of us. But realistically, as it stands, the bill is unfeasible, and healthcare professionals and patients alike are not really comfortable and sure of what's going to happen. But having said all of that, in the essence of time, penny for my thoughts, I just think that the public health space has become so politicized and is now viewed through a partisan lens. A high level of patient healthcare for everyone is unaffordable as it stands. The people of South Africa have lost trust in the system. We all need to adopt a more patient-centered care approach. One other thing that I want to say before I leave the stage is that even we need to introduce traditional healers in our primary healthcare system because they play a major role and they determine the time that a patient, that patients go to traditional healers. Let's train them, let's include them, let's involve them to make access to healthcare better. Thank you.
Thank you, thank you. And we're sorry, in essence of time, but I do want to have one thing, housekeeping. It is very hard for patients to tell their stories. And if you could please give your full attention when patients are talking, because you could be missing some pertinent information. And Toomey has given some pertinent information. I've seen a lot of people talking and in your phones and ignoring her. So we're not here to entertain, we're here to inform. So please give us your attention. So our next speaker, please forgive me, I cannot pronounce your last name. Dr. Well, is he here yet? Oh, okay, I'm so sorry, I apologize, I oversold that he wasn't here. So we are moving on to Dr. Gidambara, is that who's on the line? Oh, Dr. Lateef is online. Okay, I have the wrong name on here. Okay, can we introduce Dr. Lateef, please? And Dr. Lateef is, I'm sorry, we are running short on time here. Dr. Lateef is a regional advisor at the Department of Universal Health Coverage Health Systems, responsible for healthcare quality and safety programs at the Eastern Mediterranean Regional Office of the World Health Organization. Dr. Lateef is also a professor of preventive medicine at the University Hospital of Monastir, Tunisia. And is there anything else I need to do to get him started? We'll take it away, Dr. Lateef. Hey, I'm on it. You have it? Okay. Technical difficulties? It'll be all right. Okay. We're about to do a dance party. You got some music. Hey, let's have it. Let's go. Get up off the feet. Let's go. Stand up, everybody. Come on. Okay, now we're not gonna do that. Let's go. Come on.
Have no sunshine, come on, May, for something
All right. So as I've introduced myself, I work for the National Department of Health, and we're also a member of the IHF. And yes, quite a good interest in terms of health systems. So today I'll be talking about driving quality care in the UHC. We all know the Sustainable Development Goals that talk to UHC, and the main issues is around calling for achieving universal health coverage, which then talks to financial protection and access to quality health services.
Dr. Relabole. Dr. L. Thank you. I'm going to do that. Dr. L. How can you enhance the patient-centered treatment in your center? How can you enhance patient-centered care?
All right. So I think the journey that has taken us a bit of time to actually bring in the patient-centeredness approach. And
Mr. Wami, can you start?
The training platform. So from how we train our healthcare workers, there has to be a more.
Dr. Mondi, can you start?
Because remember, patient-centered is not just about.
I need to share my screen.
You can share the screen now.
But how are you?
We can hear you also.
It encompasses so much, and you do need to put that.
Do you see my screen now? Do you hear me? Okay, thank you, Chair, and greetings to everyone. And apology for this technical issue. So I would like first to thank the organizers, the World Patients Alliance, for giving me this opportunity to share with you this presentation, which is about the universal health coverage, moving towards better health. So I would like to refer first to the Sustainable Development Goals. And as you know, the 2030 UN United Nations Sustainable Development Goals provide a shared blueprint for peace and prosperity for all people and the planet. And as you see, the goal number 3 is good health and well-being. This includes the target, the SDG 3.8, which is to achieve universal health coverage, including financial risk protection, access to quality essential care services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. So universal health coverage means that all people should have access to needed health services of good quality without financial hardship. And universal means everyone. And of course, obviously, the coverage should cover the prevention, the whole continuum of care, the prevention, the promotion, the treatment, medicines, rehabilitation, and palliative care. This is the cube, the universal health coverage cube, which has 3 dimensions. So ideally, we aim to have the whole cube filled in blue, but this can be achieved gradually. In this cube, we have 3 dimensions. On the left side, we have the population who is covered, and the aim will be to extend to gradually to non-covered. And the right side, we have services, which services are covered, and there is a need to include other services. And of course, the third one on the top, which is the direct cost, the proportion of the costs covered. And then the aim is to reduce cost sharing and fees. And of course, we need to ensure service quality, user satisfactions, clinical quality and safety, and quality, equity, and efficiency of the healthcare services. The global monitoring of progress towards universal health coverage refers to 2 indicators: the coverage of essential health services based on some tracer indicators, and we have the service coverage index, and also the proportion of a country's population with large household expenditure on health, a share of household total consumption on income. And here we have 2 things: the financial health, the financial hardship, which relates when you spend more than 10% of the income, and the catastrophic spending on health, which when it exceeds 25% of the income. So this is the the service coverage index. And as you can see, many countries across the world with social health insurance struggle to cover the whole population. And if the entitlement is linked to contribution, some people will not be able to pay. So when there is there is no universal population coverage, vulnerable population will have limited or no access to services. And financial hardship may be experienced in countries with 100% population coverage, which means which depends on the services that are covered. And here we have some examples. The black dots are catastrophic incidents, catastrophic expenditure. So here the message that financial hardship may be experienced in countries with 100% population coverage, which is a prerequisite, not a guarantee of universal health coverage. Unmet needs can be significantly and high in income countries as well. And you can see in some countries, there is even though high income countries, unmet needs for healthcare due to cost, distance, or waiting time by income group in the European Union, as an example. So the objective that WHO as an advocates for is to ensure universal health coverage with a focus on the primary care and primary health care. And you see that primary health care approach, this is the action framework that has the primary healthcare approach, the primary healthcare levers, and the primary healthcare results. For the primary healthcare approach, we need to have an integrated health services with an emphasis on primary care and essential public health center functions, the empowered people and communities, and the multi-sectoral policy and action. So we have three things: the integrated health services and essential public health functions. We have the primary care as the first line, the first contact, and the multi-sectorality that define the primary healthcare approach. And we have some strategic levers for the primary healthcare, like political commitment, governance and policy frameworks, funding and allocation of resources, engagement of communities and other stakeholders. And at the operational levers, we have the model of care and also the point number 12, which is systems for improving the quality of care that are of utmost importance as well. The primary care, why? Because it's the people's first contact. It ensures a people-centered approach because it's organized around the health needs and expectation of people rather than diseases. It's comprehensive as it delivers a broad spectrum of preventative, promotive, curative, and palliative care. It is continuous because it connects people with trusted providers who address their ongoing health needs throughout their lives, coordinated because it manages care across levels of health system, referring patients to specialists as needed and effectively following up to ensure improvement. Accessible, offered within people's communities at a price they can afford. It is also important to note that high-income countries spend over 8% of global health expenditure, but account for only 16% of global population. And the message here is no universal health coverage without global solidarity. Solidarity is very important in the journey towards universal health coverage. What are the steps that can be taken in order to achieve some progress and achieve milestones and take action for achieving universal health coverage? 6 steps. First, to lead, to ensure political leadership beyond health, commit to achieving universal health coverage for healthy lives and well-being for all all at stages and as a social contract. Second, to protect, leave no one behind, pursue equity in access to quality health services with financial protection. Also, legislate, regulate, and legislate, create a strong enabling regulatory and legal environment responsive to people's needs. Also, advocate, uphold quality of care, build quality health systems that people and community trust, invest more, invest better, sustain public financing, and harmonize health investment. Last but not least, collaborate, move together, establish multi-stakeholder mechanisms for engaging the whole of society for a healthier world. So this is the key points that I wanted to share with you regarding this presentation. Thank you for your attention, and back to you, Chair.